Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I want to welcome you to another of my live streams, another show of my live streams, and also want to thank you for those watching this on replay. For those that are here live, you can ask me anything, and I will answer the question for you, whether it's related to intensive care, critical care, or intensive care at home. And we'll be going for approximately 1 hour. And you can type your questions into the chat pad, or you can, simply connect with me here live on the StreamYard link. I've posted the link in the chat pad, so you can connect with me live here. Now, I also, if you like the content that I'm making here on YouTube or on other platforms like Rumble, X, Facebook, Instagram and so forth, click the like button, subscribe to my YouTube channel, or, connect with me on LinkedIn, and share the video with other families that need help, because that's what we do here, to support you in your journey when you have a family member critically ill in intensive care or outside of intensive care and you need intensive care at home. You're not alone. We are here to help you. So what makes me qualified to host a show, Emergency Questions and Answers for Families in Intensive Care and Intensive Care at Home? I'm a critical care nurse. I have worked in critical care nursing for over 25 years in 3 different countries, where I have worked as a nurse manager for over 5 years in intensive care, and I've also been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very, very confidently say that we have saved many lives for our clients in intensive care with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. And you can verify it on our intensivecarehotline.com podcast section, where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are currently sending our critical care nurses into the home, predominantly for long-term ventilation and tracheostomy adults and children, but also for home TPN, home IV infusions, potassium magnesium IV antibiotics. We provide central line, PICC line, Hickman's line, as well as port management at home. We're also looking after clients on BiPAP, CPAP without tracheostomies. We're looking after clients on tracheostomies without ventilation. We're managing cough assists at home, cough assist machines at home. We are also providing ventilation weaning at home, as well as palliative care, similar to Intensive Care Hotline. We've been in business now since around 2012, and we've delivered hundreds of thousands, if not millions of hours of intensive care at home nursing for our clients and their families. We're also providing NDIS support coordination level 2 and level 3, as well as TAC and WorkSafe case management. Now, without further ado, let's go into today's questions and things that happened during the week that I believe are worthwhile sharing here. So this week I was on a call with a hospital with one of our members. We provide a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. So one of our members has the following situation. They have their 40-year-old daughter in ICU with a tracheostomy and on dialysis. She's off the ventilator. She's had a hemorrhagic stroke, and her GCS is probably 8 to 10 at the most. She's stuck in ICU, and she's been stuck in ICU for 2 years. Now, this particular hospital, and this is a hospital in the US, it's in South Carolina. I'm not going into more detail than that. wants to send her to a skilled nursing facility in New York State. Now that's crazy. It's highly inappropriate. It's undignified, and it's not in the best interest of a patient and their family. Now keep in mind, this is a young lady with 3 young children, right? And her mum and her dad, thank God, are strong advocates, and her mum in particular, has reached out to us in a desperate plea, to help us keeping her around her family and not let her go to another state 12 hours away from home. This is just sheer craziness, and it just shows how broken the system is, because it's not about what's best for a patient or for the family. It's about what's best for the system. So in any case, thank God her mom and her dad are strong advocates and say this is just so inappropriate. And they reached out to us for help. So what have we done? We've looked at the medical record so far, and it is abundantly clear to us, with all of our extensive experience with intensive care at home, that this lady can go home. No need to go to another state to continue care and treatment in a skilled nursing facility, which would not be equipped to look after tracheostomy and dialysis anyway. Now, if this lady was in Australia, we could easily take her home with intensive care at home. We're operating all around Australia with intensive care at home. But, with all of our insights, we help families in intensive care all around the world, regardless, just simply because of our insights, right? And because of our experience. So it turns out, when we were on the call with the hospital, with a case manager, with a nurse practitioner, with one of the ICU doctors, that they were saying, well, going home is not an option. We've looked at all options, and the only option is for her to go to another state, to a skilled nursing facility. Well, in my experience, in my extensive experience, that is going to be a death sentence. Skilled nursing facilities, or LTACs, in the US are not equipped to look after ICU patients. That's the bottom line. So the hospital started the meeting with, oh yeah, no, we've looked at all options, and there's no way that she can go anywhere but to another state 12 hours away, to a skilled nursing facility. There's no other opportunity, no other option. We've looked at everything, they said. So then I asked what I thought was a relevant and also important question. I said, so do you have community services in your city that look after tracheostomies in the community? They said, yes, we do. Okay, all right. Do you have community services that do dialysis in the community? And they said, yes, we do. So I said, so why would you not combine both? Why would you not send 2 services to this lady's home to A, look after the tracheostomy, and B, do the dialysis? No, we can't do that. The nephrologists have said no, right? So the services are there, but the family has been told it's not an option, right? It might have taken an outsider to, think about community nursing and think about the combination community nursing and intensive care, because that's our specialty with intensive care at home. We're looking at everything that's happening in intensive care, and how can we adapt this in the community? How can we make this happen for patients and families in the community so they don't have to live in ICU for 2 years like this lady has been? So there was very much a can't do attitude from the hospital instead of can do attitude. Instead of looking for a nephrologist or a renal specialist that is prepared to do dialysis in the home, especially with critical care nurses, with dialysis nurses, you just got to get them out of the hospital and get them in a home care setting. That's all it is, right? It's no more complicated than that. And if you have a tracheostomy nurse anyway, to look after this young lady at home, you will also be getting a dialysis nurse. right? Or you might have even a critical care nurse that is also familiar with dialysis, right? The next thing that I said is, well, if the local nephrologists are not willing to take the responsibility for dialysis in the community, in this day and age, in 2025, with all that is out there with telehealth, I said, there must be a nephrologist, maybe not necessarily in South Carolina, but maybe somewhere else in the US, that is willing to oversee a dialysis program in the community. There must be someone out there. The hospital hasn't even looked. They say, oh, we've done everything. No, you haven't. No, you haven't. You've just gone with the path of least resistance, which is we can't do it. We have to send this lady 12, 15 hours away to another state, taking her away from her family. That is unheard of. Hospitals must do better than that. They must do better than that, right? And then after the meeting, or at the end of the meeting, I should say, they put the burden back on the family saying, oh yeah, if you can find a nephrologist, then maybe we can help you. That's the hospital's job. They have all the contacts. You know, a hospital has the contacts with other health professionals. Most community services have contacts too, but I do believe the hospital has a duty of care to help this lady to go home to her family and not go to a place 12, 15 hours away, to a place where she can't be looked after by the staff anyway. So, and this is what I keep saying here, what I've been saying for a long time is, you know, number one, the biggest challenge for families in intensive care is that they don't know what they don't know. The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That's number one. The next thing that I've been saying for a long time here is the intensive care team is not even telling you half of the story. That's exactly what happened here. They haven't even told the family half of what's going on, half of the options that are available. You know, my brain is all about connecting, okay, what's happening in ICU and what can we do in the community, right? And that's how you create the resources, and that's how you bring the right people together to make it happen, right? It also makes you wonder, does this hospital potentially have any affiliation to that skilled nursing facility in New York? You know, are there any financial, you know, flows from one facility to another? Are there any kickbacks? You know, let's just call it for what it is. Why would the hospital not look at local resources first? Why would they look 3 states away first and not look at local resources? Well, it just took asking the right questions to look at local resources first, right? So a lot of it comes down to, you know, how you look at things. And if you are not asking the right questions while you have a family member in intensive care, I can tell you, you'd be losing an uphill battle. You'll be fighting an uphill battle, and you'll be losing that battle. Right? So I hope that's a valuable lesson in here, you know, for everyone watching this. Okay, if you have any questions, type them into the chat pad or simply connect with me live on the StreamYard link. I've put the StreamYard link in the chat pad, and you can talk to me live here. So let's look at another question that has come in during the week from a reader who says, my mother is in ICU with high CO2 and PCO2 is at 71 in the arterial blood gas, but her oxygen saturation is normal. What should we do? That's a very good question. So the reader says, "Hi Patrick, my mother has been an asthma patient for over 20 years, but in the last 2 years, her health has been getting worse. She was recently admitted to the ICU with very high CO2. CO2 is carbon dioxide. The PCO2 in the arterial blood gas was at 71, and she had low oxygen saturation. After 4 days of ICU treatment, her oxygen levels are back to normal, but her CO2 remains at 71. What should we do next?" So let's break this down. If your mum is in ICU with a PCO2 of 71, that is dangerously high. Normal range is between 35 and 45 millimeter per mercury. That means it's nearly double the normal range. Even if oxygen levels are back to normal, that doesn't mean everything is okay. It just means the oxygen issue is under control for now, probably with supplemental oxygen or ventilation support. But CO2 or carbon dioxide is a very different story, and if CO2 stays too high, it can lead to, number 1, drowsiness, number 2, confusion, number 3, lethargy, and number 4, even coma or death if not treated properly. This is also known as type 2 respiratory failure. Oxygen might be okay, but the lungs are not blowing off enough carbon dioxide. So why is CO2 still high after 4 days in ICU? There are several reasons for that. Number 1, severe long-term asthma can lead to air trapping and poor exhalation, causing CO2 to build up. Your mother may also have COPD, which is known as chronic obstructive pulmonary disease, or asthma COPD overlap. She might have chronic CO2 retention, and the ICU team may not be managing this aggressively enough. She may need ventilation support that focuses on removing CO2, not just giving oxygen. So what should be done now? Here is what I would do if this was my mother. Number 1, ask the ICU team, is she on BiPAP or any non-invasive ventilation? BiPAP is a non-invasive ventilation mode that can help remove CO2, carbon dioxide, and reduce the work of breathing. If not already started, this should be done as soon as possible. Number 2, check oxygen levels carefully. Too much oxygen can be dangerous. In patients in ICU who retain CO2, carbon dioxide, giving too much oxygen can make CO2 go even higher. Ask the ICU team, is her oxygen being titrated carefully? What's her target oxygen saturation? Number 3, request a respiratory or pulmonology specialist. If not already involved, get a specialist to review her treatment. This is critical. Plan for the long term. Home BiPAP might be needed with intensive care at home. If this is chronic, she may need non-invasive ventilation at home to prevent hospital readmissions and improve quality of life. And we can do that with intensive care at home. So go and check out intensivecareathome.com for more information there. Number 5, ask for updated ABGs, arterial blood gases. Is the CO2 or carbon dioxide trending down or staying the same? This gives you a clear picture of whether the current treatment is working or not. What questions should you ask the ICU team? Well, number 1, why is her CO2 still at 71 after 4 days? Is she on BiPAP? If yes, what are the settings? Has she had new ABGs or arterial blood gases today? Are we looking at long-term options like home ventilation support with intensive care at home? And what is the risk of CO2 narcosis or coma? And what is the plan if her CO2 doesn't come down? What I would be specifically asking is, why have they not started BiPAP? If they haven't, they may have. It seems to me like you didn't even know that BiPAP is what's needed here, or what is an option. That's number one. The next thing that you need to ask is, what are her PEEP and pressure support, or IPAP and EPAP levels, right? And if they have done the BiPAP, why has it not been effective? Are there some missing links? Is she not tolerating the BiPAP? Does she potentially need to go down the track of a tracheostomy? Hopefully not, but I've seen those situations before as a critical care nurse, having looked after hundreds, if not thousands, of critically ill patients and their families over the decades. Final thoughts. If your mom is in ICU with a PCO2 of 71, you must act fast. Don't let the ICU team discharge her or move her to a ward without addressing the CO2 or carbon dioxide issue. You need a long-term plan. Chances are she might sustain irreversible brain damage if the CO2 level is not reversed, or she might even go into palliative care or hospice care and die. You also need to keep asking questions, keep pushing for answers, and don't stop until you know your mother is getting the right care and treatment, which is best care and treatment. And what you need as a family member is peace of mind, making informed decision, control, power, and influence. Make sure your loved one gets best care and treatment, always. So, I hope that helps you understand what needs to happen when you have a family member in intensive care with high CO2 for asthma or COPD. And like I said, 4 days is too long, and this is why I'm saying, if you go into those situations and you don't start asking questions from day one, this family has already lost 4 valuable days, right? You need to take full responsibility when you have a loved one critically ill in intensive care for outcomes. You do. The families that we work with, that we can help the most, are the ones that take full responsibility for outcomes, and they take our advice and then run with it. That is an incredibly important ingredient for managing intensive care teams successfully. And I know how lonely this road can be when you have a loved one in intensive care. I understand that. It's a very lonely road, but we are here to help you one step at a time, hand-holding you through this extremely difficult and often traumatic experience, right? So, I have another question from one of our members that we're currently working with, from Mark. Mark says, "Hi Patrick, my son remains ventilated with FiO2 down to 40%, but with a high PEEP. A tracheostomy is scheduled for Friday, though he may still be borderline for the procedure due to a high PEEP of 14. If you don't know what PEEP is, PEEP stands for positive end expiratory pressure, and it's the pressure left in the lungs at the end of a breath to help keep the airways and alveoli, which are also known as air sacs, open so gas exchange can continue. Lower PEEP, which is also known, generally speaking, as less than 10, is usually preferred before tracheostomy because it means his lungs are more stable and can tolerate the procedure more safely. Continued coordination with ENT specialists, anaesthetists, and respiratory therapists and ICU nurses are essential to optimize your son's readiness for the tracheostomy procedure." So, but let's look at the question in much more detail. Whilst I've given some answers to the questions already, let's look at this question in much more depth. So, can a tracheostomy be done with high PEEP in intensive care? That's basically the question Mark has. So it's a question, by the way, we get a lot of times from families in intensive care. So can a tracheostomy be done when my loved one is still on high PEEP? Now, if you are watching this, it's probably because your loved one is ventilated in ICU and the team is either talking about a tracheostomy or they're delaying it using a high PEEP as the reason. Let me break it down for you in simple terms, as I always do here at intensivecarehotline.com. So what is a PEEP and why does it matter? PEEP stands for positive end expiratory pressure. It's the pressure left in the lungs at the end of exhalation, designed to keep the air sacs, also known as alveoli, open. This is critical when someone's lungs are very sick, like in ARDS, pneumonia, or COVID, or trauma, because it helps with oxygenation. Generally speaking, a PEEP of 5 to 10 centimeters of water is considered safe and stable. But once your loved one needs a PEEP of 12, 14, or even higher, it means their lungs are still in trouble and dependent on that pressure to stay open. So, when the ICU team says we're not sure if a tracheostomy can be done at PEEP of 14, they're not entirely wrong, but they're not telling you the full story either. And this is what I'm saying. ICU teams are not even telling you half of what's going on unless you know what to look for, unless you know what to ask. So, can a tracheostomy be done with a high PEEP? Yes, it absolutely can, but it is not ideal. Let me explain in more detail. A tracheostomy is often done when your loved one has been ventilated for more than 10 to 14 days. Tracheostomy is also often done when your loved one is not waking up or not strong enough to come off the ventilator, or if they're failing spontaneous breathing trials or CPAP trials, or if the breathing tube in the mouth, also known as endotracheal tube, becomes a long-term risk, for example, for vocal cord or mouth damage. But here's the catch. If PEEP is too high, like 14, there's a risk that the lungs are collapsing or oxygen levels are dropping during the tracheostomy procedure, so that oxygen levels drop to dangerously low levels. That's why ICU teams, surgeons, and anesthetists get nervous. So what's the real answer? The real answer is this needs a skilled, coordinated approach. I've seen tracheostomies done safely even on a PEEP of 14, 16, or even more, if it's done by experienced hands. It therefore requires full coordination between ICU, ENT anesthetists, and respiratory therapy and ICU nurses. Ideally, FiO2 should be coming down below 50% and PEEP ideally less than 10 centimeters of water. But again, I've seen it done higher when needed. ENT or ICU should have a plan to keep the lungs recruited during the procedure, sometimes using apneic oxygenation or jet ventilation. It can be done at the bedside, which is also known as a percutaneous tracheostomy, or in the operating room, also known as surgical tracheostomy, depending on your loved one's condition. Risk versus benefit. Delaying the tracheostomy because of high PEEP also has its risks. Number one, longer sedation and longer use of opiates. Both I strongly oppose. If it can be reduced, it needs to be reduced. 2, higher infection risk from prolonged intubation. 3, more difficult to wean later on. 4, potential tracheal damage from prolonged endotracheal tube. Sometimes even with a borderline PEEP, if a tracheostomy is still the lesser of two evils. What's my advice? Don't just accept we quote unquote can't do a trach because of PEEP, the PEEP is too high as the final answer. Ask instead, what's the plan to lower the PEEP and FiO2? Can the ENT or anaesthetist evaluate if it's still safe to proceed? Can it be done with extra precautions? What are the risks of waiting versus doing it now? Remember, you need to ask the right questions so the ICU team knows you are informed, not just sitting on the sidelines passively. I hope that helps. We fight for families just like yours so you can make informed decisions, have peace of mind, control, power and influence so that your loved one gets best care and treatment always. So, you can't take anything the ICU team says for gospel. The stakes are simply too high for you to just roll over and take everything for gospel. Like I explained to you at the beginning of this video, if I hadn't asked the right questions with this family in South Carolina this week, the ICU team would have pushed for this lady to go to another state. And now, the home care option is opening up. You can never take no for an answer. Never, ever take no for an answer. Always have options, solutions. Do your research. ICU teams have their own agenda, and it is not always your agenda or your family member's agenda for that matter. Okay, now I need to look for the next question that has come in during the week. It's just going to give me 1 second. In the meantime, type your questions into the chat pad or simply connect with me live here on StreamYard. Click on the link that's in the chat pad and you can talk to me directly here. Don't need to go on camera. You can just talk to me speaking to me. Okay, so what is next here? I just got to look through my messages. Where is it? Yes. Okay. Here's a question. So, does my dad need a tracheostomy and or PEG tube in ICU, or can it be avoided? And this is coming from one of our members. We have a membership for families of critically ill patients in intensive care, and you can become a member. And if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly in the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. And this is one of the questions we answered this week. So, can the ICU team says my dad needs a tracheostomy and or PEG tube. Can this be avoided? So, this was our answer. Your dad, who has advanced Parkinson's disease, hypertension, high cholesterol, chronic urinary retention, and a history of pulmonary embolism, was admitted on the 18th of June 2025 after a mechanical fall that caused a subdural hematoma, a bleeding in the brain, and he underwent a craniotomy on the 19th of June for evacuation of the bleed. Since then, he has shown signs of neurological improvement. He is awake, intermittently following commands, tracking with his eyes, and he has a Glasgow Coma score of 10. Glasgow Coma scale is a tool to assess your dad's consciousness. And, we've made a whole article about that on our website. If you go to our website at intensivecarehotline.com and you type into the chat pad or into the search box how to assess Glasgow Coma Scale, that's when you get a link to an article. So your dad was extubated on the 20th of June, but he had to be reintubated on the 21st of June. So extubation means the removal of the breathing tube, and intubation means the insertion of the breathing tube. He got reintubated because of an inability to manage his secretions, not because of respiratory failure. He remains on minimal ventilator settings, FiO2 30%, PEEP of 5, with vital signs stable, his recent arterial blood gas on the 25th of June, with good oxygenation. Arterial blood gases, or arterial blood gas tests, also known as ABGs, are there to check how well the lungs are working. How good is the gas exchange, i.e. oxygen into the bloodstream, carbon dioxide out. On examination, your dad's lungs are clear, breath sounds are equal, no signs of pneumonia, which suggests that his lungs are functioning well and that he may be a candidate for another extubation trial with better secretion management. According to standard clinical protocols, a tracheostomy is typically only considered after 10 to 14 days of failed ventilator weaning or repeated failed extubation attempts. In your dad's case, he is alert, showing neurological improvements, and remains on minimal ventilator settings, which suggests he still has a good chance of coming off the breathing tube with the right support. Therefore, a tracheostomy is not necessary at this point in time. The primary barrier to extubation has been oropharyngeal dysfunction and difficulty managing secretions, likely related to advanced Parkinson's disease. However, there's no evidence of new neurological injury affecting the swallowing reflex directly. Your dad's care team is suggesting a tracheostomy and PEG to prepare for a transfer to LTAC, but we strongly advise against a transfer to an LTAC. His condition will most likely worsen there. He should remain in ICU with a respiratory neurointensivist, also with ICU nurses, of course, and the Swallow team support, as he still has a very good chance of being safely extubated without needing a tracheostomy. And for those of you who don't know what is an LTAC and what am I talking about here when I say a transfer to LTAC, so here's what you need to know about LTACs. LTAC stands for long-term acute care hospital or long-term acute care facility. It is unique to the US healthcare sector only. LTACs do not exist in other countries. It is very unique to the US. And from my extensive experience, LTACs are a disaster area. And you can verify that by a number of things. Go and have a look at your LTAC in your area. Have a look at the online reviews from patients, from their families. Go and have a look at the online reviews and compare what the actual LTAC is promising on their website, and see whether the two match, whether what the LTAC is promising on their website they are doing, whether that matches with family reviews. And you will see that it's not. We've got so many families over the years that have reached out to us, begging us to help them get their loved ones out of LTAC. I've also made a video a while ago, 10 reasons why LTACs in the US are a scam, right? So whenever you hear LTAC, your alarm bells need to go off. As for the feeding tube, your dad's currently getting nutrition through a soft tube that goes into his nose, a nasogastric tube or a Dopphoff tube, and he's tolerating that well. He has not had any signs of vomiting or aspiration. A PEG tube, which is surgically placed in the stomach, so it requires a surgical procedure, is generally not needed unless someone cannot eat or tolerate feeding long term. Now, that's not the case for Dad. It's very early days. Since he's receiving adequate nutrition for now, a PEG tube should be avoided at this point. In summary, based on his current condition, alertness, stable breathing, and ability to receive nutrition, your dad does not need a tracheostomy or a PEG tube. Now, that does not mean that he definitely won't need a tracheostomy or a PEG tube, but for now, there's no need for him to get a tracheostomy. He still has time to be weaned off the ventilator, right? And if he can be weaned off the ventilator and go back to baseline, that is the best solution here, right? And you should always aim high. Now, intensive care teams may not aim high, and in this situation, their goal might be to do a tracheostomy and a PEG tube and send your dad to an LTAC, out of sight, out of mind. And that is unfortunately what a lot of LTACs are doing, what a lot of ICUs are doing, right? They're not acting in the best interest of the patient. What's the best interest of the patient here? So compare two situations. Compare your dad getting off the ventilator and the breathing tube not needing a tracheostomy and moving on to rehabilitation, moving on to a hospital floor, to a hospital ward, and going home. Compare that to needing a tracheostomy and needing to be further weaned off the ventilator, or needing to be further, treatment in an LTAC, including a PEG tube, right? Now, also what our viewers need to know here, right? So let's just say you would be agreeable to a tracheostomy, and let's just say your dad would need a tracheostomy. Okay, maybe it comes to that point, we couldn't rule that out entirely. Do not give consent to a PEG tube. Here's why. Once your dad, or any ICU patient for that matter, in the United States has a PEG and a tracheostomy, they are prey for LTACs. Why? Because LTACs pretty much take any patient with a tracheostomy and a PEG tube, right? Now, if your dad needs a tracheostomy, we're not opposed to that. If all other avenues have been looked at, everything has been done to avoid a trach beyond the shadow of a doubt, it's just not working to wean him off the ventilator and he needs a trach, do not do a PEG tube. And here is why. Most LTACs, not all, but most LTACs do not take patients without a PEG tube. So if your family member has a tracheostomy and a nasogastric tube, they can't go to LTAC in most cases. But that should also tell you everything you need to know about an LTAC, that if they can't look after a nasogastric tube, that should be extremely worrying for you. Extremely worrying for you, because it's telling you everything you need to know about their skill level, which is extremely poor, extremely low, right? To go from a nasogastric tube to a PEG tube is really for patients that will never wean off a tracheostomy, will never wean off a ventilator, or it's very unlikely, such as spinal injuries, such as spinal injuries or cerebral palsy or Rett syndrome or spinal muscular atrophy, stroke, that's when a PEG tube might become a necessity. But not in this situation. It's way too early. Way too early. Okay, let's look at the next question. But while I'm looking through my emails, if you have any questions, please let me know. Type them into the chat pad or connect with me live here on the StreamYard link. Okay, let's move on then. I have another email here from one of our members. It says, "Hi Patrick and team, thanks for checking in." And this is a member who has their sister in ICU on a ventilator with a tracheostomy with cerebral palsy. And she's been having her sister in ICU for months on end. And she's looking at options to go home. Again, this is a lady in the US. And, again, if she was in Australia, we could take her home with intensive care home, no problem. We're not in the US yet, but in Australia, she could go home. But let me read out her email. Hi, Patrick and team. Thanks for checking in. We've been busy with my sister's care and still trying to advocate for her to get all services she needs to get her home. This really goes back to the hospital not ensuring she had a solid discharge plan. And this is what you need when you go home with intensive care at home. You need a solid discharge plan, which is what we do with intensive care at home. We know how to get a solid discharge plan. In the hospital, dumping all the responsibilities on us. We were assigned to a home health agency that has also been extremely difficult to work with. The only reason I tried to continue to work with them is because we had already been working with their OT in the past and had been making some progress. Now, let me tell you something about, home health agencies in the community when it comes to long-term ventilation and tracheostomy. It is so specialized that you can't just take any home health agency, right? I argue there's no other provider worldwide that employs hundreds of years of intensive care nursing experience in the community, which is what we do with intensive care at home, right? So you have to have the skill and the workforce to set up, provide, maintain 24-hour rosters at home with ICU nurses. That's a skill. You can't just take someone home from an ICU and hoping and praying. Hope is not a strategy. You need to know what you're doing. So let's continue in the email. It was the home health agency's job to draw her labs post-discharge. However, they said they never got the order and needed a doctor's order. The doctor's office said they sent it to them, but again, the home health agency just kept saying they didn't have it. Well, and I know the history there. She did go home a few months ago, but it was falling apart within a few days, right? No surprises. It is the home health care agency's responsibility to make sure that everything is aligned, including how the doctors work. This has gone on now for 4 weeks. No, hang on. This has gone on now for 4 weeks. We kept hearing it would get done, and then all of a sudden the home health agency discharged her from nursing services, saying we have 24/7 nurses and therefore they are not needed. They said this would not change her access to getting the OT, physiotherapy and labs. However, as soon as they quote unquote claimed they had the order for labs, they are now saying they won't do it as they already discharged her nursing services. Discharging her from a nursing service when someone is ventilated in tracheostomy is literally a death sentence, right? It's also not evidence-based. Discharging someone on a ventilator with a tracheostomy, it's not evidence-based. And the reason I'm saying that, I argue we are the only service in the English-speaking world that provides evidence-based care. So have a look at our website at intensivecareathome.com and have a look at the evidence-based mechanical home ventilation guidelines. In the mechanical home ventilation guidelines, you will see what is actually needed when it comes to ventilation and tracheostomy at home. And what is needed is critical care nurses 24 hours a day, and those critical care nurses need to have a minimum of 2 years critical care nursing experience, ideally with a postgraduate critical care nursing qualification. And, similar to ICUs, we have over 50% of our ICU nurses are critical care postgraduates, right? So we're very proud of that. That, again, once again, is, I believe, we're bringing the highest skill level in the community. So then the email continues. This is so unfair to my sister as we have been waiting to see what her levels are, and it's important to avoid hospitalization again. I called her insurances, Medicare and Medicaid, and filed complaints with both. They said the only way to get a home lab service through insurance is through home health. So that's a catch-22. They said they would call the home health agency and we could be transferred to another home health agency. This has been such a waste of everyone's time and has been extremely frustrating. I feel like our medical system is not supporting people's needs in the home and how critical and crucial the care is. Do you have any recommendations on this or on anything else we can do to enforce these needs? Yeah, like I just said, quality care, right? You cannot go home, and you know that because you've already, one discharge has already failed. You cannot go home without critical care nurses 24 hours a day. It's as simple as that, right? You need a strong team. You need clinical governance behind, the discharge and behind the home care setting, so that you know what needs to be done. One thing that I believe we're doing extremely well at intensive care at home is that our clients are staying at home predictably, not randomly, right? We are now going to see if another company from our respiratory therapists can get funded by the regional center to provide that service, at least for now, until we get insurance to step in. Things are different now with her being on a ventilator all the time. And it's not so easy to take her in for labs or other medical services. We're trying to get everything we can done at home. I'm surprised at how challenging these services still are despite her very clear needs. There's also no accountability. We have been following up with her doctors via Zoom appointments, and this has been somewhat helpful. Yeah, I agree that when someone goes home on a ventilator, unless you have the right team, the right service that has the intellectual property, the know-how, the policies, the procedure, what needs to be done, this is doomed to fail. And I can understand why, not having intensive care at home in your area, why it is so challenging. But, again, if you were in our area, or in Australia, we would just set it up and run with it. And your sister would be at home, just like all of our other clients are at home. And I agree with you that there's often no accountability from services, but it's also not easy. It takes a whole team to do what we're doing, and we want to do it well, of course, it is extremely important that you have the right people on the bus, so to speak, right equipment, right setup, right discharge process, right equipment. Right? Without the right equipment, once again, this is doomed to fail. Without the right team, whether it's the 24-hour critical care nursing team, without the right physio, without the right doctor overseeing it, without everything that needs to happen, this is all doomed to fail. But we have a solution, I believe, for almost everything in this space. We have answers to everything in this space. It is absolutely possible. And, we can often set it up within 2 to 4 weeks, going home from ICU. We've done it many, many times. There's case studies on our website at intensivecarehome.com. No big deal. And we've got clients that have lived at home for many, many years, whilst ICU was pushing for palliative care and end-of-life care and hospice and saying, oh yeah, this person won't have any quality of life. Well, ask our clients. Tom, nice to see you again. I absolutely do have plans to replicate our service in the US. I absolutely do, but we are so busy here. And I simply don't have the boots on the ground in the US yet. Haven't even made a trip to the US yet because we are so busy. We are expanding into other states in Australia now. But the demand is there, Tom. We're having inquiries from the US every week. I'm talking to people in the US every week, inquiring about intensive care at home. So we know the demand is there. The challenge in the US is we would need to select a state where to start, because you need a home care license in any state, really. Whereas here in Australia, we can work all around the country with no limitations, really, with just one license, So it is way more difficult to select the right state. Whilst I have some ideas, because I can see where most inquiries are coming from, I would still have to be certain that, okay, we're going to start in this state and we can get a home care license there and get people on the ground. We also have employed critical care nurses in Australia from the US, and they have gone back to the US, and I'm in contact with them. And I say, tell me what's happening in the US. They say, well, just get someone and get it started in the US. Because they've worked for us here, they know that the issues are the same. you know, and you can see, you know, what I'm talking about here. It's not really location dependent or independent, you know, that the issues are the same. People want to leave ICU. You probably know best, Tom, in terms of with your son, you know, what you need. And the issues are the same, you know. Yes, to answer your question, yes, we would love to come to the US. Once we are probably, once I have a little bit more time, I can't foresee when that's going to be. But yeah, absolutely, because the demand, we can see the demand is there, you know. So look, I'm going to wrap this up here in a minute. If you have any other questions before I wrap this up, please type them into the chat pad now. Otherwise, I will wrap this up in a minute. If you like my videos, subscribe to my YouTube channel. Click the like button, share the videos with anyone that you think will benefit from, you know, the videos that I'm making here. And keep your questions coming. Email them. Let's start in Virginia. Tom, I know you are in Virginia. I know you and I have had many discussions over the years. I'm not sure. The most populous state at the moment that I think is also business friendly is Texas, and there's also a lot of inquiries coming from there. But you know, I have to travel around the country. I've been to the US years ago, but not me thinking that I would run this one day. So I have to travel around the US. But most inquiries right now are probably coming from Texas. And Texas to me also seems to be a very business friendly state. You know, I don't want to go to a woke state, you know, where all these communists are in charge. You know, I want to go somewhere where it's business friendly. But we'll see. We shall see. I need to make a trip to the US. Okay, I do need to wrap this up, guys. Thank you so much again for joining. I will do the same again next week. If you need help, if you have a family member in intensive care, go to intensivecarehotline.com. Contact us there on one of the numbers. I also do one-on-one consulting over the phone, Zoom, WhatsApp, whichever medium works best for you. And if you need intensive care at home, go to intensivecarehome.com. We're operating all around Australia and all major capital cities, as well as in all regional and rural areas. And I want to thank everyone again, and I'll talk to you next week around the same time. Look out for the emails. Look out for the emails during the week, and also for the quick tip videos that are coming during the week. Take care for now.